Thank you everyone for joining us this afternoon. I'm very excited to be here. I feel I have enticed many of you to come and disagree with me, so I'm a bit scared of that now, but but hopefully we can agree on some of the topics as well. So we're here today to talk about ways to improve care for people that are living with Huntington's disease. And I will be mainly presenting findings from my research project, which is connected to my PhD work at the University of Southampton. My work has been funded by the National Institute of Health and Care Research in Wessex. I've been lucky to get a scholarship there. So the work has been funded by NIHR Wessex, but it doesn't mean that they have agreed with their ideas. So the ideas are mine and of my team. It's just a disclaimer. So on today's session, then we'll go over the improvements that are needed to the care that are offered to people living with Huntington's disease. And this is with particular lens focused in the needs of people living in England. Okay. And that's because the study collected data about people living in England. So I want to present the results, but I also want to get your feedback on it. The idea is that I take you through a journey of the PhD from 2020, the findings up to today. So who am I and why should you listen to me? So as John was saying, I was a research nurse at University Hospital Southampton for nearly 8 years. I was working on a neurodegenerative research team doing clinical trials and observational studies. I've been also a nurse for 14 years, so I'm no longer on that post, but I continue to be a nurse. Academically speaking, so that's me now inside that blue circle, joining in the computer, and that's the research team at the University of Southampton. So that's my new reality because I'm mostly joining remotely as I've moved back to my home country, which is Portugal, 2 years ago. So I do a lot of work locally in Wessex remotely. And I also work with lots of national, European, and international organizations connected to the Huntington's disease field and to the integrated care field. I've been trying to be merging the two of them in the past years. Education-wise, I'm a guest lecturer at a Polytechnic University here in Portugal, at a School of Health Sciences. And I do a lot of voluntary work as well for the Portuguese Huntington's Disease Association here. We've just started a team to support families that live in the center, more remote part of the country in Portugal, and also to reduce loneliness in the elderly. So that's a little bit about me. This is my team that has supported the project. So I have quite a multidisciplinary supervisory team, which has been very good because amongst them, I have a neurologist, a physiotherapist, a nurse, a sociologist, and also a person with lived experience leading the project from that side to make sure I keep the patient at the center of the project. My research questions when I started the study, I had two. So my main question was, what does integrated care need to look like to meet the needs of people living with Huntington's disease? And how do we measure these changes? How do we know that these changes are person-centered, are working at a person and a carer level? So my PhD has been a bit like an onion. So if we start from the middle of the more center circle, you'll see there's a literature review. So I wanted to understand what had been done in other neurological conditions to learn from what had been done already, not to reinvent the whole wheel. Then I went to do a survey nationally, which was the Integrate HD survey, to understand actually how were things, how far were we from the ideal. And then I moved to do interviews to understand better what people's needs were and what is it that they wanted. And then I moved to understanding in terms of priorities, what were they? So I did consensus workshops end of last year to be able to rank the priorities. And then in the end of the PhD, I will have hopefully a model that meets the needs of people living with Huntington's disease in England. And I will go a bit over the ideas for the model today, but I want your feedback on it before it's finalized. So I'm going to start with what I found when I looked at the findings, when I looked at the results that were out there in the literature about other conditions. And when I mean other conditions, I looked at Parkinson's disease, multiple sclerosis, and Huntington's disease. And I sort of knew what was going to happen, but I needed to prove instead of just giving a thought to it. So actually, I found no data in Huntington's disease. I was looking for interventions that had been tested that were able to improve collaboration between different teams and different services. And I found studies in Parkinson's, I found studies in multiple sclerosis, but nothing on Huntington's disease. And when I looked at the interventions in the other conditions, and I tried to understand what made them successful from the perspective of patients and families, these were the 4 characteristics they had. So they were actions based on expert knowledge. So they had a team, an expert team delivering care. They were person-centered, which meant the care plan was being based on their needs, designed with the patients and the families. They had a coordination of care, and usually this coordination was done by an actual person in a formal role, so a professional as a care coordinator, usually a nurse or a social worker in these projects that I looked at. And they had continuity of care. And this meant that the team was continuously caring for their patients. They were having a regular follow-up, say every 6 months they were being seen. And that way the team knew the patients and the families that they were taken care of. But what I understood is when they tried to evaluate these interventions, they mainly focused on measuring things that were not so important from people's perspectives. So, for example, they measured a lot of numbers such as admission to an A&E or how long did they stay in hospital, instead of focusing on measuring, for example, if the continuity of care had improved. And if you want to know more about what's in the literature, I've put here the link for the full paper, which is freely accessible. It's published open access. So then I moved into the survey. So the survey, I wanted to know, okay, so this is what makes integrated care successful in the other conditions, but I found nothing on Huntington's disease. So how is care in the Huntington's disease world at the moment in England? And again, I sort of knew what was going to come out, but I needed to prove my point. So actually the survey, so 153 people took part on that survey. It was run in 2023. And it spotted a lot of fragmented care. People said that they had different teams caring for them, but they didn't really communicate with each other. They're working in silos. The carers said that they really felt ignored, that they were not being heard when designing the care plan or deciding on treatments, for example. And there was postcode lottery, which meant depending on people lived in the country, they had better access to resources, and those resources were not available equally across the country. The other thing I spotted, which was a big problem, was that GPs and social workers were said to be very involved in the person's care, but actually people didn't find them knowledgeable. And this actually meant that a lot of the decisions that were being taken were harmful to the patients and the families. So people are involved, but not knowledgeable about what they are doing. And then people said, we need a care coordinator. This is very important. So people said it was very important to have someone to help them navigate this mess that is care currently. They're just so diverse. They said it's very important, but then only 19% said to have such a person, which is extremely low. And again, it shows this postcode lottery. But the people that did have access to a care coordinator had a much better experience with living with Huntington's disease, and that shows a difference. So in terms of what support was mainly needed, people said they needed mental health support, they needed family support or support for their family, they needed financial support and social support, okay? So again, it doesn't really tie very well with measuring admissions to hospital or how long did they stay in hospital. These are the people's main worries. So mental health, family, social, and financial. And again, I have a lay report you can access to, which is also on the HDA website. And if you want the full scientific article, there's the link for it there as well. Then I want to stop here because I've told you now about what's already done and published, which was what I found on the literature and what the survey found. And I touched lightly on these ones, on these topics, because I want to focus on what have I been working on from then. But I wanted your thoughts on this first part and to make sure that you are listening to me and not just chewing on your lunch.
Sandra just saying that it seems to reflect their experience.
For sure, yeah.
Yeah,
Okay.
and someone else. Yeah, so two people. Yeah.
Okay, so this is interesting. For example, someone from Wales saying that it's transferable, sort of like across, um, which is I found this. I actually had people from the US and Canada as well contacting me because they wanted to take part on the study because they felt that again the findings really resonated with their experience. And again, Canada and US is such a wide geographical area. Again, South Africa as well saying so. I find it very impactful that, when we're in our bubble, we think, oh, this is terrible. It's much better in other countries. And it is much better in other countries, certain countries. For example, I found it very good in the Netherlands, but it's a much smaller country. So it would be interesting to see if we can raise the bar, not just in England, because there are certain aspects that do need to be improved across the border, or not so much the border in UK, but what else? Yeah. So someone very rightly saying that if we want to understand joined up care, how can we improve different teams working together? That perhaps looking at medical measures, it's not particularly helpful. And we are talking about a disease that is progressive. So, if it really is not the best way to understand these things because the disease will continue progressing.
Sandra, there's a question just in the
Oh,
Q&A.
okay.
Someone's asking, did your survey include participants from minority ethnic backgrounds?
Oh, I love this question. Uh, yes, it did. And actually, so okay, so on the survey, um, I don't think I asked for people's ethnicities. I actually asked for very limited amount of information in relation to the person that was completing the survey. And the reason for that was because when I ran the survey through the group of people that live with Huntington's disease that support my study, so they contribute to the study because I don't have lived experience of Huntington's disease. So they come with their lenses of actually being embedded in families living with it. And they felt that a lot of the questions were adding to the length of the survey, which was, I mean, I don't know if any of you took part on it, but it was already pretty long. And actually, some of them, I felt it was unnecessary to ask because, for example, we already know that people from minorities have a harder have a harder time to reach the care that they need to access. So access is worse for people from minorities. And also, for example, questions on the education, the level of education. I also um, didn't focus on that because people gave me feedback that they felt it was blaming them for not having like a better access to care once again. So on the survey, I didn't focus much on what was their personal characteristics so that I would keep the survey completely anonymous. This was done online. So I had to reduce the amount of identification asked from the person. It's not that difficult to spot people, and when you're trying to use quotes, and I wanted to make the data accessible, so actually all the data is now accessible to anyone that wants to continue working on it through the University of Southampton, all anonymized, of course, as people consented for this. But I didn't ask about their ethnic backgrounds. I did record this for the interviews and the consensus workshops, and I'm happy to say that I think 11% of my participants were from other ethnic um, backgrounds beyond and white and English, which is what it's trying to be achieved by the NIHR, because we understand our research needs to be more representative of the population that we do have in England. Hope that clarifies the question.
I think
I see a lot of agrees.
there's a lot of agrees, a lot of people agreeing about like the difficult, maybe the GPs not um,
Mm,
being someone saying that I have to spend time explaining things to the GP. I think that maybe the GP doesn't know, which is obviously that the burden being put onto like families to explain rather than the GP being there as
mm,
a sort of
mm.
with the knowledge. So yeah, and uh,
Okay.
and there's someone there saying that you know that similar with social workers.
So again, it's very consistent across different countries. I see we have people joining us from other countries as well, and this need for the actual families and patients to advocate for themselves and explain and keep explaining. And then because it's not just that the GP doesn't know about the disease more frequently, it's that the GP also keeps changing, and then you have to keep explaining to different people, what the disease is and how does it affect you and what do you need. So you almost have to go with a problem and the answer to it, to the professionals that don't know enough about Huntington's disease. Okay, I'm relieved in a sad way to see that a lot of the findings who are quite negative resonate with you. That's why we're here. So next. Okay, so I'm gonna move now more towards the present 2020, well, 2024, 2025. As I said to you, I conducted interviews and workshops because the survey is very limited in the depth of information that it can give you. And it already painted a pretty dark picture of how HD care in England was, but I wanted to also work on the answer and not just on the problem. So with the findings, so I did 24 interviews in the space of 4 months. And these interviews were mainly focused on people that do live with Huntington's disease on their day-to-day, either because they're gene positive, they're at risk, carers, past carers. And when I say about carers, I mean family carers or friends. I don't mean professional carers. So I interviewed 15 people with lived experience, and I interviewed 9 professionals from different sectors. And these need for interviewing the professionals. And although I wanted a response or a solution that is focused on people's needs, it's very important to get the professional's perspective on what is possible, what's feasible, and actually, what sort of obstacles are in the field, or what could promote, an intervention if we want to move ahead with testing something. So it's very important to have these professionals' perspective as well. But it was mainly focused on people with lived experience. And from these information, then, as I said, we had a 3-hour workshop. We had 5 groups over 2 days, and again 24 people. Some of them the same, others were new participants to the study, and a better split of people, but 13 with lived experience and 11 professionals from different sectors. And these were mainly professionals who are experts in the field. Okay. All right. So I do have to make a statement here. So this work is not published yet. I'm working on the manuscript and finalizing the analysis. And you've put a statement here that it cannot be reproduced or distributed without the consent of the authors. But I do want your views on it, so I'm willing to take a risk today here. So when I looked at the categories that come out on the interviews, these are the main categories. So what I have is the care characteristics, sort of like what does care need to include to be successful? There were a lot of concerns that are divided depending on the stage that the person is through the disease. If the concerns of someone at risk are very different from the concerns of someone with advanced Huntington's disease. There was a lot of conversation about the burden of living with Huntington's disease and how do we manage that burden. And then I've focused on what interventions could we do and how would we measure it, and actually what are the obstacles and facilitators. And I can't take you through all of it because you would have a very long session. But don't be overwhelmed about this. This is like researcher talk. What I want you to look at is actually on this corner on the top right. There is a section that says unavoidable burden, and the other one says avoidable burden. And I know burden has been a word that not everyone likes to see it associated with Huntington's disease. But what I mean is there is burden, there is suffering involved in living with Huntington's that is avoidable. So there's added pressures because we're not being able to, and by we, I mean the system, we're not being able to meet people's needs. And so we're adding to that suffering. If someone, someone's already living with a chronic disease and they can't get the help that they need, that adds burden. And I don't think I need to explain, to many of you living with the disease that this is like that. And then I wanted to focus here on the blue side, which is the characteristics, which I will talk a bit. And I mainly wanted to know, how does care need to be framed to respond to people's needs? So it's the same characteristics that showed up when I did the literature review, which were continuity of care, expert knowledge, person-centered care, and coordination. But in my study, it adds a new dimension, which is family-centered care. So the other interventions I looked at that were focused on Parkinson's disease and multiple sclerosis were not picking up on the need to care for the family. And that might be because of the nature of the studies. It may be because of the nature of the disease as well. But in Huntington's disease, this shows that it is crucial to look after the family. Okay, so from the 4 quadrants, we had, I'll be adding family-centered care. That is essential to look after the family because, as we know, as an hereditary condition, Huntington's disease doesn't stop if the person passes away. Usually there's multiple people affected, and the same person can be affected by Huntington's and be a carer for another person. So it's much more complex than in other diseases. Also, if we look at person-centered care, it keeps showing that we need people to self-manage. And I particularly get a bit crossed with this self-management approach, because we can't tell people to self-manage if we're not giving them the resources and the tools to do so. So in my opinion, if we're advertising for people to self-manage and make your own decisions without giving them the tools to do so, for me that's neglect. That's just poor care, poor service from providers. So we need to empower people, give them the tools and the resources to be able to self-manage. And as we know, in Huntington's disease, it does come a point where the person is not able to self-manage and someone else will do it for them in their best interest. So there is this added layer of vulnerability in Huntington's disease that we need to account for. So this vulnerability, you can't always be depending on a spouse, for example, to chase the services, to ring. The care needs to be proactive because, as I said, we're not just caring for the person, we are caring for the family. So we can't be expecting the carers to always be in a good state of mind and have the time and the headspace to chase. Okay. So I will be highlighting the need for proactive care, for the services to ring proactively, before a crisis happens, to understand how people are and pick up on the needs before they turn into really serious. Okay. So a bit on evolution about the characteristics that we see as key in Huntington's disease care. And actually, you might say, I knew this. This is common sense. I think, as we've seen, there is no common sense in the world at the moment. And if we don't build the evidence, we cannot expect the government, for example, to take action for change. Okay. So that's why I'm building the evidence and sort of pointing the obvious. So here are some quotes about, for example, the need to empower the families. So generally, Parkinson's patients notice that and recognize that and change it themselves, whereas the Huntington's patients cognitively can be quite a lot more impaired and don't recognize it so well. So you have to do a lot more work with the families. So the need to empower. And these are quotes from actually providers. And this is to show that providers that are expert in Huntington's disease, they see these, they are on your side. Now, on the proactiveness, on the vulnerability, these participants said it has to reach crisis. Somebody has to set fire to their house or wave a knife around or something for people to react and get the intervention that they need. And it shouldn't be like that. We shouldn't let people get that distressed or that unwell. Again, the need to take action proactively before there is a crisis. And then on the family centeredness, I think that would be very, very helpful for the families, because the families need as much support as the patients, to be honest, because they're going through an awful lot, aren't they? So just some quotes to represent. So what improvements do we need to do in HD care? So in theory, this is what we're seeing. We need 5 characteristics. We need the expert knowledge, the continuity, the coordination, and we need care to be focused on the patient as well as the family. And in theory, in my head, this sounded like a sonar model. So on the top figure, what you see is the person that is gene positive and the family that is also affected and therefore is also colored. And you have these multiple layers like an onion, except it's not quite an onion because they're not separated. These teams are sometimes around the patients at the same time, but doing their own loops. Okay. So we have, for example, the GP, we have other community resources, expert teams. So I've added here things we do need, which is an expert team with a social worker, for example. So we have the expert knowledge and the coordination. The coordination is given by someone that needs to tie up all these layers, which is the HD care coordinator. And what people is saying is, I don't care who takes this role. I don't care if it's a nurse, a social worker, occupational therapist. I just need someone to do it, to know who it is, who do I link with, and who's helping me navigate this system. So we have the coordinator tying those ends. And then what we need people to understand is the disease will be progressing, and unfortunately, people will lose capacity to decide for themselves in a lot of aspects towards the end of the disease. But there are things that are quite visible. So we see the person that is affected by the disease, but we need to account for the family, which is also there, but it's, their needs are very neglected at the moment. We look at the healthcare needs from people, but we need to account for their social care needs, which also, again, are a constant. We have people that have capacity, but then we need to rely as well that this capacity will fluctuate. So people are very vulnerable. And actually, if carers become also overwhelmed as the disease goes by, as they're struggling, if I have a migraine, I don't have the same capacity to make decisions than if I'm feeling well. So this vulnerability, it's not just from the patients, but as well from the relatives. Again, how much are we asking people to do and in what circumstances? And again, those physical needs and the mental health needs, which you already know, it's a huge gap in England. So what we have here is that we need continuity as the disease is progressing, but we need a proactive system. We can't just be throwing signs and not listening if they come back to us. If I'm waiting for a patient for an appointment, and if a patient doesn't show up, DNA did not attend, how rude. No, why did they not attend? Find the time to ring them afterwards, understand what is happening, because it's very easy to say that people are not engaging with services, but why are they not engaging? So we need that exchange, that communication. We can't just expecting people to always coming to us. We need to go to them as well. So in practice, okay, so when I ask people, here are a list of interventions that people have suggested. So ideas about care improvement. And I'm going to show you where do they agree or not so disagree, but where they diverge. So on the interventions, when I ask people that provide care and people that are using care, they all said that the number one priority is care coordination. We need someone to take this care coordination away from the patients and from the families. So that means a professional that is bridging the different systems and the different teams that knows the patient, knows the family, okay? And yes, we can't stick a person in a role forever and make them stay there. But that's why you shouldn't rely on just one individual, because people get sick, people get pregnant. That's why you need the team, and you need to keep your records updated as well, and your training protocols updated, so that if a person, is absent for some reason, it doesn't collapse the whole system. So people ask for a care coordinator. They also ask for an HD hub. That's how they put it. So a one-stop shop with multiple experts, including a social worker that can link with other professionals. So this HD hub would train other professionals, because again, it's not like they can provide all the direct care, but they can train other professionals, be responsible for that upskilling, which is actually a model that works very well for Parkinson's patients in the Netherlands, for example. So where do they diverge? So service providers really highlighted the difficulty they have themselves as professionals in getting mental health support for their patients. Okay, so they said they needed a mental health HD link, so someone that they are able to train, because there are mental health teams spread all over the country. So to identify someone to take an interest in Huntington's disease, train them up and know that in that county, that mental health team is that person that has some knowledge of Huntington's disease. Okay. And then they also highlighted the need for guidelines. And, the HDA has said we had put our will forward to get Huntington's disease specific guidelines that unfortunately was rejected in our first submission. But professionals are saying we need this guidance. Again, it's a very complex disease, and we need to be able to provide care based in the evidence, okay? Not just what we learn with years of trying it out and know what works best. While the users are saying that they need to know what community resources are available for them. So they said it would be good to have someone that can identify and signpost to these resources. Again, it could be that care coordinator that knows well their local resources is able to do this signposting. And then, as we spoke actually in the beginning, the need to have GPs trained in Huntington's disease. So people gave an idea of having a core group of GPs in the counties that is trained to look after the people that live with HD in those counties. So these were some of the suggestions people gave. Why oranges? So there are so many interventions that were suggested, and some of them are really hard to put in practice, to translate to practice. So I thought it could be useful to have almost like a tier system of difficulty, or as I called it, hanging fruit. So to maybe have it divided as low hanging fruit, intermediate, and high hanging fruit. And I divided some of these suggestions. You'll see there's other suggestions here that I didn't comment before. I divided the suggestions into the core characteristics, the expert knowledge, the coordination, the continuity, person and family centered. So, for example, low-hanging fruit on family-centered care, to provide a one-to-one appointment for the carer. Carers need specific time to have their needs reviewed. And for example, there are expert teams in Huntington's disease that have their appointments with the patient, take 10 minutes of that time or adds 10 minutes of that time to speak with a carer. Okay. And this is not about trying to divide people. No, it's an appointment dedicated to check that person, that carer, and that's something they've asked, and that how hard. That's way more easier than a lot of the other ones. So what you see highlighted in yellow is when I asked people to rank what was more important. Okay, so I've highlighted in yellow. So for example, signposting to community resources is relatively a lot more easier than to create an HD hub that everyone has access to. But the fact that there are, different degrees of difficulty shouldn't stop us from making, smaller improvements. Okay, so my point here is that maybe there is a way to start and work towards what is more difficult and a higher priority, but there's already changes we can start thinking about. So I'm gonna stop here again to have a look at the chat and the Q&A. I've put some prompt questions, which were, do you think these are the most important care characteristics, or, do you disagree with any, or would you add any? And mainly also for professionals here joining the call, if it's helpful to have the activities organized in this like tier system, sort of like, from what would be easier to implement to what would be harder to implement, and we need to make a plan to work towards. So the Q&A button is clear. So the people ask for respite opportunities or residential care. Did you find that palliative care was supportive and knowledgeable? Okay, so for respite opportunities and residential care, yes, people ask for it. One of the things people asked for was appropriate care settings, as in there are a lot of nursing homes or residential homes that the staff or the facility, not or probably and the facility, are not uh, prepared to receive patients with Huntington's disease. And this has triggered a lot of issues, of course, with people becoming so progressing more rapidly. For example, having admissions to hospital that should have been unavoidable. People not being stimulated cognitively in the way they should, that being put together with very elderly and frail patients when actually, they have a lot more energy and would like to do different activities. So that is something, yes, people have asked for. In regards to palliative care, it's not one of the findings to be highlighted, but palliative care was also spotted as one of the teams involved. And what people spoke of was their main concern was to have a good death, as in to be able to make advanced life decisions when they have capacity, that those conversations would be brought up in a timely manner. And that what they are scared of is to have a bad death experience. And again, this comes through generations, the ripple effect that it is that your past experiences affect what you're scared of now. So yes, that's something people have covered. What else? Let me see.
Sandra, there's a question just above that. Someone asked just a bit earlier saying, I wonder what you were classing as care for the purpose of the research. I just asked
Is
because there's
care
such
for
a lack.
the
I'm a carer for the person with HD in the UK. There's no care. They have one appointment per year with an HD clinic.
mm. So I asked people what's so the way I phrased questions on the survey, for example, and I imagine that that's what the question is referring to, is to the survey, or maybe to the interviews. On the interviews were quite open, so I could explore what services do you use currently, if you need help, who do you reach out to? So the questions were phrased in a much more flexible way and actually guided by what people wanted to talk. It was quite an open interview guide for to go with the flow sort of thing. So it's not like I gave them a definition of care. I've asked them about um, the teams they would interact with. Tell me about your experience with Huntington's, and then from there try to understand. For example, the question we had about um, residential care. Um, I didn't have that phrased, but people as they move through, I had this experience with my father, for example, so they move towards there, which was a concern. So I didn't spell it out. um it was more about people's needs. What is it that you need when you need, for example, when you have a question about Huntington's disease, who do you go to? It was phrased in a more nuanced way so that I wouldn't be boxing or guiding people towards a specific thing. Another thing I'm seeing here about difficulty in accessing talking therapies, for example. Um, so, so people asked for like non-pharmaceutical interventions. A lot of people actually. And I think that links out actually well with the fact people ask to be signed towards community resources. So therapies, yes, people were asking for therapies, but also social groups, classes they can attend, or not just exercise classes, but again as a hobby, as to socialize, to have that appointment to get out of the house. Um, Let me see, moving down. Levels of difficulty are valid, but commissioners put off the most difficult, example, a hub or coordinator. Yes, and that is why my plans post-PhD is to test uh, the most important interventions in practice, be able to measure that, and my theory is that long term we will be sparing money. So we will be sparing money to the government, and that should give reason to be adopted. Okay, because a lot of the crisis would be avoided. But I understand if I go now, to so well, NHS England has been sort of like changed. But if I go now to a decision maker with the results I have currently, they're not going to decide, yes, let's put an HD hub, in each, I'm not going to say each county, but, even, a broader area speaking. They're not going to do it just because I'm saying people want it. They will hopefully do it once I prove that it spares money, it spares I mean, again, theoretically, it would improve the workforce satisfaction as well, because as we know, people are leaving the care roles. Uh, often it's very hard to recruit people to. This rotation of staff is really impactful. So the care force needs a reason to want to stay, but also this money that uh, it's being sucked by because we're just reacting to consecutive crises that are happening instead of investing in preventing them. And then again, not that it would make them apply anything, but the amount of suffering people are going through, if they had access to expertise, it would be so different. But the intention is to do a sort of like a study where I can prove, compare the regular care with the intervention being applied. Okay, so hopefully that would entice the decision makers to spend that money on it. So I was developing following a co-production model, business case. The level of difficulty should help guide care providers on creation of new roles or review current roles to incorporate support. I do believe it is detrimental to have a consultant that is passionate about it and continues to advocate for the need and impact these roles can have. Okay, so this is actually very important because one of the things it came out, and I'll talk a bit about it, it's the culture and the difference it makes if the individual is passionate about what they're doing. So I'll cover that in a bit. Okay, so I'm conscious of time because I'm Portuguese and we can talk forever. So I'll talk a bit about the measures, what people saw as successful. Um, so again, different tools to measure, but what should we pick? Because what's been done so far is to focus on the clinical progression. And again, we're talking about a neurodegenerative disease. So that's really not the best way to assess if services are coordinator, to look at a person's cognitive status, for example, or if they're using health services more or less. If people are not going to their neurologist as much, I don't take that as a positive thing directly. So for me, we need to be very careful with this. And again, you might look that we're sparing money at first, but I doubt that is the case. So I've compared what providers and users thought And I just wanted to highlight one of the comments I got from a user, which was, again, I gave them a list. This is like a second page. And what the person said was, the problem is that all of the above is required. So I think people found it really hard to score because they felt all of it was important. And it was all important because they were the one creating the list. So they know better than anyone. So what I have, and I'm just simplifying it. So people agreed that in terms of measuring success, it would be successful, or a good measure would be access to expertise, okay, to access to that expert Huntington's team, to have a single point of contact. And so knowing who to contact. Okay, again, I asked the question, do you know who to contact? So a lot of the people picked up that actually they don't know who to contact at 2 p.m., let alone at 2 a.m. when they have a problem. Okay. And then the other measure was quality of life, okay, which was not surprising. Then providers thought access to care was the best, one of the best measures, while the users focused on, are the appointments worth going to? You know, are the appointments focused on what matters to me? Am I making decisions about my care plan on what matters to me? Okay. And then also focused on the family levels of anxiety and stress. So it should be a program that lowers the anxiety. And this takes me back to the avoidable and unavoidable burden, because there is burden that is avoidable. Okay, so these are the same quadrants. I've just added some of the measures. For example, do you trust the professionals that are involved in your care? That's another one of the ideas of how we should be measuring these type of interventions. So my take-home messages today are 5. The first one, you can't have self-management if you're not giving people the resources, you know, if you don't empower people to self-manage, because otherwise it's pure neglect. It's like telling professionals to be resilient, but not giving them more staff to work on the wards, which is what they need. So I have an issue with self-management and resilience. So give people the tools and then they can self-manage. Then a knowledgeable team that can upskill other professionals around, because we know that an expert team cannot provide all the care. Okay, so we need to upskill other professionals involved. The care needs to be focused on the family needs. And again, we have children, we have elderly, it's across generations. We need to focus on the family needs as much as we focus on the patient, because really, who's the patient? So we need stronger connections between physical and mental health. We already know it's extremely hard to get mental health access. So we need, for example, to have that HD link in each team. And we need a better social and healthcare integration. For example, to have a social care worker in every expert team. And then a care coordinator that can bring it home really and tie it all together and be that single point of reference for the families. So to touch on the comment we had earlier, I had this quote, which is, how a society treats its most vulnerable is always the measure of its humanity. And I do think at the end of my interviews, it was a very higher thinking in terms of, it's the culture, it's the society, it's the mindset, and how do we promote this from, for example, the degree level. You know, when people that care are doing their degrees, you know, if mental health nurses could learn about the brain, if neurologists would learn more about mental health, perhaps we wouldn't have all these so fragmented from such early stages. I want to thank the people that have contributed to the project, not just the participants, but actually my patient and public contributors who have helped me design every single step of the project, which is not finished yet. So I will continue bothering them. That's my promise. And that's it from me.